Folks, welcome back to the next episode of the Dental Implant Podcast. And I am really pleased to have a friend and colleague join us today. And when I say friend and colleague, Nigel and I go back quite a number of years. And Nigel has been quite instrumental in some of my earlier years, showing me the ropes unofficially, because we worked in the same practice. We've worked in a number of same practices on and off over the years, haven't we, Nigel?
We have.
And, the reason why I've asked Nigel to come over today is Nigel was with us on the Implant Summit about a month and a half ago. And his lecture on overdentures was just incredible, mind-blowing. Now, for you guys who are listening now, you know that I've said before in the past that I hate overdentures. I think they're a load of rubbish. They don't work. I can't get them to work in my hands. Nigel opened my eyes, and I've actually started to offer overdentures again to my patients. So Nigel has re-inspired me on that aspect. For somebody who really doesn't like overdentures, that's really saying something. But he had a number of points which we're going to cover today. And just so you're aware, Nigel got your Implant in prosthodontics, is that correct?
Yeah, it's restorative dentistry.
Yeah. So Nigel's got an Implant in restorative dentistry. He is one of the loveliest and most giving guys that you'll ever come across. It's absolutely fantastic. Very giving with his knowledge. So Nigel used to run one of the courses for Tipton training, and you have your own academy now, Nigel. Is that right?
Yeah, we've been running largely restorative courses for about the last 10 years.
Yeah.
Sometimes modular. The mainstay is a 12-day modular course, which we run over 6 months, 2 days a month, over 6 months. But we also do lots of standalone 1 day, 2 day courses as well. Most of it restorative, but some of it implant restorative. I've not ventured into the surgical teaching as yet. I think guys like you and others do that very well. And it's something that I think we'll look at in the future. But for now, it's mainly the restorative side of things.
And Nigel, just so that people understand your wealth of knowledge behind this, when did you first place your first implant? How long ago was that? I'm not trying to age you, my friend. I just want people to understand that when you're talking, that you are talking from a point of authority and experience. So when did you first start placing implants?
Well, historically, I qualified 88, so that's going back some years now. But I had a general practice in Sheffield, initially NHS, which we then took out of the health service. And that's the point that I thought I need to upskill, knowledge and skill.
Yeah.
So I started various courses at that time and started implant courses in about year 99, 2000. I then moved to Paul Tipton's practice, where I got a wealth of experience, initially purely restorative. So between 2000 and 2005, I was 100% implant restorative, which I think gave me a pretty good background as to the surgical side of things to come. I've got a good basic restorative knowledge and skills. We were doing big cases day in, day out. I started placing implants in 2005, so 20 years ago. I placed my first implant.
Perfect.
And from that time, really, my whole practice has been centered around dental implants and restorative work.
Yeah, fantastic. So for those of you listening, is you can understand that Nigel's had a lot of training, restorative based to start with, and then obviously moving over to the surgical side. Now, Nigel, there's a few things that I think that are really important that we should cover. And where this conversation organically grows is absolutely fine as well. So please feel free to take it in whatever direction that you feel is necessary. But the main touch points that I would like for you to cover, firstly, are the medico-legal aspects, which was really interesting that you discussed. Because obviously, when I'm talking about full arches, I predominantly tend to do fixed. And I turn around and say to my patients, if you want something removable, I don't do that, go elsewhere. Although I've changed now because I've learned a lot from you, even in that hour and a half session that you did for me. But there's certain medical legal aspects in regards to making patients aware of their options. So that's one thing I'd like for you to touch on.
Sure.
And the other couple of things I'd like for you to touch on is why do you think people are hell-bent on fixed as opposed to removable? And then the next point after that is, what are the benefits of removable over fixed? Because obviously removables get a bad rap, but you know what you were showing on the on the Implant Summit, mate, it was incredible, and I could see why it makes such an improvement to patients' lives. So from my point of view, the touch points are the medical legal aspect, why people tend to err towards fixed as opposed to removable, and then the benefits of removable over fixed, if that makes sense.
Sure. Yeah, absolutely. I think you're right. I think medical legally, one thing that I was always taught is to, at a consultation, not to dictate the treatment plan. In other words, not to try and make the decision for the patient. So I think that patients in a consultation position should be given the whole array of options. Now, I'm not trying to confuse patients. We don't want to give them too many options. But I think medical legally that we should say to patients, okay, you're going to lose all the remaining teeth. So you're going to become edentulous. So the first option then, of course, is dentures. And that's probably quite rarely given these days, but it's an option. Then we'll move on to the overdenture options, which there are usually a couple of different levels. And then the fixed option is the fourth treatment option. So broadly speaking, where I have a patient coming in for a consultation for full arches, be it a single arch or a dual arch, then I think that initially we need to give them the dentures, overdentures, and fixed bridge route. I think the criticism at the moment, maybe across the board, is that everybody tends to jump in at full arch fixed restorations. I think the publicity of marketing is geared towards full arch fixed restorations. And I think a lot of the training as well is geared towards full arch fixed restorations. Whereas, where do you go to learn how to do overdentures? Most of the implant teaching, most of the implant courses that are out there will go thread through the needle and give dentist skills in either guided surgery or non-guided surgery, whichever is your preference. But it's all geared towards all on 4, all on X, immediate loading, fixed, etc. So I think the competency of most implantologists is very good in that field. There are lots of us out there. I do loads of fixed restorations, as do you. And I think that is well mentored, is well taught. And I think we're producing clinicians that are giving a really good clinical level in the results they're achieving. But I think there's a whole host of treatment plans in between dentures and fixed that is probably being overlooked. And so my thoughts medical legally are that we should be giving patients these options. In other words, every patient that sits in the chair for a full arch consultation, be it single arch or dual arch, we go through that you could have dentures. And I will generally spend a couple of minutes just saying, traditionally it's immediate dentures. Then 3 to 6 months later, you're going to need a definitive set of dentures and give them the fees for that. Most patients know and don't want dentures, but I think we have to be complete in giving them those options. Then, of course, we can move on to the options of overdentures, be it something as simple as 2 locators and a denture, an implant retained denture, as it were. Then we can move through to mill bars and horseshoe chromes or removable bridges, and then into the final fixed. So what I tend to do at consultation is go through that process with them, offer them, show them photographs of all these different options, and then send a letter out to them with those options in. And I think it's just to avoid that situation where if a patient does have fixed bridge work and there are problems, if they're a smoker, if we've got a history of periodontal disease, etc., and after a few years they start to have issues around the implants of fixed restorations, and then they go somewhere else and somebody says, well, were you offered overdentures or removable restorations, and they weren't, that I think is where problems can occur. So it's just the completeness of giving all the options verbally and in writing.
Yeah, so I agree with that, Nige. And I think one of the things that you stand out for me is that you had a case where you gave all of these options, and it said that the patient ended up going down one route and then ended up changing his mind afterwards. And because you gave him the options, he was kind of like, yeah, fine, not a problem. But had you not given them the options, they could have landed you in hot water.
Yeah. It was a case recently where it wasn't the easiest of cases, but we did fixed. We did all on six or 7 restorations, upper and lower. And he had fixed restorations in them. He was a little bit manic about the cleaning, the hygiene, and he actually fractured the porcelain on the bridgework. When he came back in, he actually said, look, I've been thinking about this. I know you gave me these options. Can we go to the option less that you originally gave me, which is removable restorations? So we did in mill bars and horseshoe restorations. So he was a patient that actually came down, if you like, from fixed porcelain bridgework, back to removable restorations. And he was happier mainly because of the hygiene side of it. He felt happier being able to take the things out, and clean them on a daily basis. And of course, then for us to be able to just unscrew the bars every 6 months with a hygienist and have everything cleaned is a much easier process than it is with fixed.
It's really interesting the level of patient psychology that actually ends up playing into this. And one of the things that I say as well is patients tend to want what you're most confident with.
Yeah.
So, a lot of people turn around and say to me, my patients won't accept autogenous grafting. I'm like, I don't have that problem because I'm very confident in speaking to it. Yeah. And one of the issues that I've had is whenever I've been giving treatment options to patients for full arch work, I've never been confident with the removable aspects. Always been much more comfortable with the fixed aspect, which, everything has its pros and cons. There's no perfect implant system. There's no perfect implant restoration. There's pros and cons to everything. But I've started to give the options now for removables, particularly on bars. I think on another level as well, Nige, is, sometimes what happens is if you're going for fixed, you can price the patient out of treatment. Whereas if you're doing something removable, it's much more amenable to the patients. So sometimes that from what you were describing, the option that the patient goes for, sometimes it's not necessarily the psychology of I want fixed versus I want removable. Sometimes actually this better suits my budget. And ultimately, at the end of the day, would you rather do a set of overdentures or no business at all?
You've hit the nail on the head, Bob. I think there is so much business being lost at the moment in clinics because these options are not being given. What I will tend to say to patients, and be quite honest and open, there are two things that dictate their treatment plans. One is bone, one is money. And, some patients have the cash, but they don't have the bone. And vice versa. We've got a lot of patients that might have plentiful bone. And we see this quite often where patients come in with the idea they've seen marketing, they've been online, they've done some reading up, but they're horrified at the price of it. So if these guys come in, a starter for 10 is to have 2 implants and an overdenture. And that might be all they can afford at this stage, which is something that we can then build on later and maybe add more implants and upgrade later. But if they're not given those options to begin with, then they're going to miss out completely. They're just going to turn around and walk out of surgery and you've lost the business altogether. Yeah. So I think that overdentures are a great practice builder. I'm not offering overdentures instead of fixed. We will always offer fixed as gold standard because I do truly believe that it is gold standard. But for some patients, it's not always the case. I think one thing you said earlier, Pav, is the confidence to offer these options as well. I think that generally speaking, a lot of dental implantologists, let's face it, implantologists either come from an oral surgery background or they come from a restorative dentistry background, with some guys from the perio background. And certainly I think from a surgical background, these guys are super hot surgeons, but have they made a set of dentures? Probably not for a long, long time, maybe never. And so the teaching aspect of things for removable prosthodontics is seriously lacking. And most probably of the implant courses that are out there that these young guys are then enrolling on with a view to doing dental implants are not encompassing the removable options as part of the course. It's all geared towards fixed work. We all do fixed work for single teeth and 3-unit bridges, et cetera, but the step up from that to a full arch is very often geared towards fixed full arch work. Whereas if a patient can't afford that or doesn't quite have enough bone, there's a couple of options that we showed on the Implant Summit where sometimes quite young patients were coming in with very little bone available. Just through perio disease or neglect, or they'd lost their teeth very early in life. And to place 3 and 4 implants and have a titanium mill bar on that with a removable bridge with a titanium insert that's milled onto the bar is a fantastic restoration for them. And it means they've not got to go through the more advanced bone grafting procedures, etc. It gives them a really great option. But again, it comes back to teaching and the knowledge, and it means that a lot of the dental implant surgeons need to, in effect, go back to school and learn how to make good dentures. I think I was quite fortunate in that I was from a generation where making dentures was initially in general practice bread and butter. We did it, and we did it for many, many years. And then you can upskill in that. Ivoclar, the PPS system offer fantastic teaching schools and great systems for making dentures. And as a dental implantologist, if you put yourself through those, then you've got the knowledge and clinical skills to be able to make great dentures. And of course, in this day and age now with CDTs coming into practices, they can be doing most of the groundwork and making great dentures. You just have to see to the implant side of it and the planning side of it. So I think there's a whole host of business in that middle ground that is probably being missed at the moment. You look at the monetary values and, for a single arch, if you're doing a couple of implants and an overdenture, you're looking at a budget of maybe £6,000 to £7,000. If you're looking at a mill bar type of restoration, you're looking at 8 or 9, probably, compared to fixed restorations of, 15 to 20, whatever people are charging in different parts of the country in different clinics. But that is a big scale of fees. And so patients can choose a budget that is right for them at that time.
It's almost along the lines of, somebody's turning around and saying to somebody, oh, you know what? Your options are to go in a learner car or drive a Formula One car. They're not in the middle.
Absolutely. And I think this is sometimes, it's not being judgmental because I think it's how people are taught and people's own confidence. Because you're right, Pav. It's not good offering dentures if you don't have any confidence in making dentures, And if you're still making dentures as you did when you first left dental school, you're probably going to fall short and the clinical result will not be great in the end. But if you can upskill and make better dentures, then the overdenture option is a serious player in this game, and I think in this day and age, it comes back to being able to offer patients this whole spectrum of treatments that will give them a great result. I mean, you touched on earlier about, the advantages and disadvantages. And I think the biggest advantage of something removable is the serviceability of it long term. You get patients with peri-implantitis, you get patients with failing implants. And if you've got a failing implant under an all-on-4 fixed restoration, you've got a real problem, to sort out. And okay, maybe the same with the bar. You can get away with maybe removing a single implant and still leaving the bar on the remaining implants. But certainly if you're going one stage less than that, you're going back to locators, then the advantage of something like that is that if you have a problem on an implant, you can remove it, you can leave it on the remaining locators, they can wear it, you can go back in and place another implant, you can then put the housings into the denture in a different position without even having to change the restoration itself, you can adapt it. So it's a great serviceability in patients that are probably higher risk patients, in the smokers, ex-perio type of patients.
So there's a couple of things that I picked on as well, Nigel, as you were talking. Firstly is we need to understand is the layers of what we're talking about. So obviously, when we're talking about locators, we're just talking studs. But one of the things that really stood out to me on your lecture, Nigel, is the level of precision that you can get to when you start doing milled bars. And, if you start doing milled bars and you have something that's located onto that milled bar, sometimes the patients really struggle to get it off. So how far is it off a fixed restoration, really? Because historically, the issues that I've had is most of the patients who've wanted to have overdentures, they've just wanted a couple of implants just to locate it. And I found, and it's probably the way that I'm communicating it, Nigel, okay, let me take responsibility on that, is it doesn't matter how much you say to these patients, you've only got 2 implants, you're still going to have a little bit of a rock. You do the treatment, they come back and go, oh, it's rocking. I said, I told you it was going to do that. We're just stopping it fully rotating.
Yeah.
I think that's where my dislike of overdentures started. But I've never done many milled bars. The couple that I have done have worked absolutely beautifully, and the patients have been thrilled with them. So I think that's something else that I need to revisit. The other thing that I picked up on as well sorry, mate, got the remnants of a cough here. Is something that you've touched on. This is really important. Is all training appears to be geared towards fixed, right?
Yeah.
All training appears to be aimed towards all-on-4, pterygoids, nasalis, transnasal, zygomatics, even subperiosteal frames and things like that. I don't remember the last time I saw a course for overdentures. So do you feel that one of the reasons why it's not offered as much as it should be is the lack of training that's available, and therefore the lack of understanding that dentists have to offer it as a treatment option?
I think it is. I think that's one aspect, that there aren't the training possibilities or opportunities. Most of the overdenture type training courses that you would go on would be denture type courses, the Ivoclad EPS system type courses. And I think for most implantologists, they probably see that as a little bit of a come down, a second best option, because I don't make dentures. I've not made dentures for years. I'm an implant guy. I do full arches and
get people out of dentures.
Yeah, exactly. It says it on my mug, on my surgical cap, on my scrubs, full arch surgeon, and all the rest of it. And I think they see dentures as a negative or a second best. And sometimes it is, but for many patients, it's not. It's a great result for them, but it's the training opportunities to learn the skills to do that I think are lacking. It's going back to school. It's learning about denture techniques, and putting those then into play into the implant field. I think there are two aspects to it. One is the training. And I think the second is attitudes. I think we probably as a profession, as implantologists, if we're not careful, we can put that persona across that a removable is second best. And it's not for some patients. It's the best option for some patients because of the maintenance, serviceability, access for when there are problems. So I think we've got to talk about overdentures in a very positive sense. You're right about what you said about the basic entry level of having two locators. You're going to get an anteroposteroidal rotation on that, and the way I tend to say this to patients is the denture is not going to flip up when you're speaking or eating, but it will move. There is movement on that. There is a rotation on that, and I think one of the problems can be with that is that it's easy for us to do a fixed head impression and then let the technician deal with all the abutment selection, putting the housings in. So we get the overdenture back, with the housings in place and the inserts in. And to be quite honest, rarely does that fit accurately. The errors that there are in casting these models and processing and then denture construction onto that model. These models often come back from the lab fractured and chipped and broken. So the denture is not that accurate. It is far better if you are doing locators to cure them chairside. So this then becomes another skill for the dentist, being able to deal with cold cure acrylics in the mouth and cure and pick up housings. But if you do that, you're going to get a passive fit on the denture. You're going to seat it in occlusion. So you're going to get a much, much better result. So again, it's the skills to be able to do that. And I think a lot of implantologists will probably shy away from that and think, well, if I do fix on 4, that's far better because it's easier. Yeah. And it is easier, there's no doubt about it. The clinical process is easier to do a full arch fixed restoration than it is to do a full arch removable implant supported restoration.
I feel the other aspect of as well is from a technical point of view, even technicians, denture making is becoming a little bit of a lost art in itself. Because what's happening nowadays is you see people turning around and scanning everything, having these 3D printed dentures which look abysmal. I don't care what you say, they look atrocious. Like, oh, doesn't it look better? It looks better than the piece of chewing gum that you spat out earlier, but it does not look like a nice set of dentures. And having spoken to a few technicians as well, I think the number of technicians being trained across the board in everything is dropping like a stone. So we are potentially staring down the barrel of, in a few years' time, having to pay very high fees for quality work that's actually dropping and dropping. Yeah. And I can see that denture making is probably becoming a lost art. Would you agree with that, Nige?
100%.
So,
I do agree. I think the dental technicians, you speak to any lab owner, and they're finding it increasingly difficult to recruit skilled technicians, particularly, I think, denture side of things. I think the whole crown and bridge is moving towards, obviously, digital. I do most of my full arch fixed digitally. Not with photogrammetry necessarily. I prefer a traditional workflow to achieve the final fixed restorations. But as far as dentures are concerned, yes, there are digital dentures out there, but I agree with you, Pav, they're nowhere near as good as traditionally made acrylic dentures. And I think technicians are finding it difficult to recruit people at the bottom end in the training capacities.
So the from a clinical aspect, so I'm just trying to summarize a little bit, Nige. So from a clinical aspect, medical legally, it's important to give patients options.
Yeah, definitely.
From a business aspect, that there's a lot of business that's not happening because people are offering all or nothing.
Yeah,
guilty. I've been doing that up until quite recently as well. Okay, I used to say to my patients, look, there are overdenture options which are available. I don't do it. So that's business that I'm losing out on. Okay, and the third thing appears to be the actual training aspect of it as well. And then finally, obviously, it's getting a good technician as well. Does that sound right, Nige?
It absolutely is. Yeah, I think I use a very different laboratory for my dentures and overdentures than I do for my full arch fixed ceramic work. But it's finding that right technician, and I think we're all finding it more and more difficult to work with great labs. I think they're getting fewer and fewer and far between, and particularly the acrylic side of things. Whether that's the historic, the idea of NHS dentures and just ploughing away with that. A lot of the implant guys now get into implantology, and they're not going back to those days. They're not happy making dentures. They don't want to be involved with it. And I think most people are now qualifying with, quite advanced qualifications in implantology. But if they've got to change a locator insert in a denture, they have no idea what they're doing. And as an implantologist, we should be able to offer all those services through the removable options up to fixed options. So I think it is training. But it's also attitudes as well. I think that I enjoy treating all aspects of treatment and giving all the options that I can. And if a patient chooses to have the halfway house option of an overdenture, then I'd like to that as well as I can and give them as good a result as I'm possibly able to. And I think you're right that at the moment, a lot of people are being offered dentures. And very often that particular implantologist might not do standard dentures, or they're offered all on 4, all on 6 fixed zygomatics, pterygoids, the whole malarkey that goes with that. But they're not being given that middle ground that would give them a great result with a lot less surgical involvement. And a result that is better for maintenance in the long run. I mean, generally speaking, when I see patients long term, overdentures that I did 10, 15 years ago, things are much healthier generally than a lot of the fixed work that we do. Because I think people do tend to think that the fixed work is like their own teeth and they can just carry on and just brush in the normal way. They're not as good with the hygiene side of it. Whereas generally, again, with the overdenture type of patient, they take the thing out and they've only got a few studs or a bar to brush around, and they can do that quite well. So the maintenance long-term tends to be better with removables, so we get less problems long term.
I think where overdentures excel and do, correct me if I'm wrong on this, Nigel, because again, I'm openly admitting I've not done that many, but although I'm aware of the technical aspects of it, is firstly in cases where you've had a lot of resorption. Okay, so the resorption pattern is you're losing vertical height, but everything's dropping back, kind of like palatally or lingually. So you get collapse of the facial structures. So this is where overdentures are definitely superior to something fixed, because you can use a flange in order to give that correct support right back to where it was. Yeah. So there is a strong chance, because the more resorbed that you are, if you put the teeth in the right place, quite often you've got a big horizontal shelf over the top of it, where fluid and plaque gets trapped in the patients complain about it a lot.
Yeah.
So if you've got overdentures, firstly, you're restoring that with a flange, but quite often you can get a nicer peripheral seal where you're not getting fluid stuck underneath it. Was that a prior assessment, Nigel?
It's a completely puff, yeah. As you say, if you've got someone with a lot of horizontal resorption in the maxilla, and you want to bring the teeth out to give the correct lip support, you've got to really bring the teeth forwards on those implants, which gives that horrible food trap shelf above it. The other thing that the overdentures get over is the transition line. If you've got a high lip line patient, and you're going to do a fixed and all on 4, and you're not able to do an FP1. Okay, FP1s are great. Lovely result in a high smile line patient. But if you've got a patient that has got a high smile line and they've got, previous perio, and you've got to do an FP3, how far are you able to take that transition line up? And there's nothing looks worse. I mean, we've all done it where we've done an immediate load, and you see the patient a few weeks after, and they smile, lip goes up, and you see the edge of the bridge, and you see the transition line. The beauty of an overdenture is you lose that completely because it's a flange right up to the top of the anterior sulcus. And no matter how big or how high they smile, it's all hidden behind the upper lip. So sometimes aesthetically, there are actually several times where we've chosen, even on probably 5 or 6 implants, to do a removable restoration on a bar because of the patient having such a high smile line.
Yeah, it's an interesting treatment option. And I know that you've just touched very quickly on FP1 there as well. So what we're seeing is that there's a lot of courses on FP3. There are a lot of courses coming up on FP1.
Yeah.
For me, it comes down to diagnosis. Not so. What I tend to find is somebody goes on a course. I'm guilty of this. I think it's just human nature, Nigel. Like, if you go on an FP3 course, you're looking for FP3s because you're excited about it.
Yes.
FP1 course, and all of a sudden you're excited about that. You're looking for FP1s. So the issue that I have is that the diagnostics have to be correct.
Yeah.
And certain cases amine themselves towards FP1, such as restorative breakdown, not really that much perio, low lip line, thick biotype, okay?
Yeah.
Other cases lean themselves towards FP3. So if you've had a lot of perio destruction, you're not going to vertically grow that bone to put the patients back into FP1. And similarly, it sounds like there is a specific set of patients where actually they would be better off with overdentures, not from a monetary point of view or anything else, but as you said, hiding that transition line. Getting the correct lip support. So actually from a clinically point of view, it sounds important.
Yeah, completely.
Yeah.
I mean, if you're planning an FP3 in a high lip line patient, high smile line patient, you've got to be really accurate with that alveoplasty. You've got to know exactly where you're going to finish that bridge. And the planning is critical. And I think, again, a lot of the time it can be a little bit blasé in the planning. Yeah, we do an alveoplasty, we level it out, but if that's not quite lost high enough, then when the patient smiles, you get a horrible transition line.
Wow.
And I agree, Puff. I think FP1s are great. I love doing FP1s with lots of tissue pressure, tissue sculpting with immediate provisional. But if you have any hint of perio, I really worry about these cases long term. Even at the 3 to 6 months when you're doing the definitive restorations, you could have had quite a change in the tissues, and a great FP1 immediately loaded provisional can look absolutely awful at 3 months, 4 months if you're not careful. So what's it going to look like in 5 years?
Exactly. So there's a couple of things that spring to mind there. Firstly, I was speaking with Howie Gluckman. Howie is one of the best surgeons I've ever seen, mate. His work's just exquisite. He's been a big influence on my career, and I've learned from him as well. But one of the things that he was saying with regards to FP1, he said the issue that you have is, yes, you will get resorption over time, and you can't always predict what that resorption pattern is going to be. So the problem that you have is in a high lip line patient, if you have that resorption, you may end up with a very, very unaesthetic result in just a few years' time. So how he's an advocate for socket shielding, partial extraction therapy, root banking, and I'm trying to get him on the podcast to discuss that. But he's right. What if you take out all the teeth and you manage to do some sort of ridge preservation, and but 5 years down the line, that it all starts to resorb away. It's going to look like crap.
Yeah.
There was one colleague who I saw who he was one of Prof. Shukrin's students, and he'd very frequently build bone back up. The type of cases that I'd look at and I'd go, this has to be FP3. He'd build it back up. His name was Alain Simon-Pierre, and unfortunately, he passed away about a year ago. But if you looked at his cases, they were immaculate. And he showed this FP1 case. And I remember saying to him, I messaged him privately. I said, I didn't want to say it on your post. I said, but what if you get resorption around that, like in 5 years' time? Then what do you do? He goes, oh, you know that case that I showed you? I said, yeah. He goes, that's the 14-year follow-up image, mate. It looks completely exquisite.
Yeah.
And then the other aspects, because I was speaking to Dave Viege as well, and Dave said the other issue that you have with FP1, just because of the biology, is you have blunted papillae compared to what we naturally have.
Mm-hmm.
And obviously, if we're talking about overdentures, you can create the papillae. So there is a strong possibility that with overdentures, you can get a much more aesthetic result in terms of absolutely everything than what you can do with something fixed.
I agree. And I think a lot of it comes down to, we all know the individual variation that we've got with patients. And even with the best planning in the world, you can place a single implant and you've got thick biotype. You just place the implant and it looks exquisite. Equally, you can do the same process with the same assessments, and you see that patient 6 to 12 months later, and you think, oh my God, what's happened to soft tissue there? What's happened to papillae? And people do react in very different ways. And so I think sometimes for implantologists early in their career, the overdentures can be a safer, more predictable pathway to get good results, rather than the uncertainty of FP1s, certainly, and the risk of the transition line in FP3s in high smile patients.
Nige, I feel like you've answered all my questions, mate. Is there anything else that you feel that we haven't touched on that we should?
No, from an overdenture perspective, I just think it's a case of learn how to do them, have a go at them, because they will give great aesthetic results with the right technician, with the right laboratory. I do them because they're a service to patients very often, particularly patients that have a strong history of perio and smoking. The most susceptible patients that we treat and see, patients that have a history of periodontal issues particularly, which correlated, in 5-10 years' time are going to have those problems around their implants with periimplantitis. And if we can design a restoration that gives us a better access and serviceability to these problems, then you're doing the patient a service rather than saying, well, you've paid all this money for a fixed restoration. In 8 to 10 years' time, as periimplantitis rates peak, that you might have problems then, So I think the overdenture option is a good option. I mean, I do as many fixed as I do overdentures, but and patients psychologically, I think, want fixed teeth. But if we can explain the difference to them and show them, I'll sit down and show them clinical photographs of what these things look like, because the patient, if you say it's an overdenture, I tend to use the term removable bridge if we're using the titanium bar type of restorations to get away from the denture type of terminology. And you show patients photographs of these, then you tend to find a lot of patients will go along with that. And as you said earlier, it's the budget as well. The budget may fit better to that. And if they come back and say, well, I've thought about all this, we're going to go with the fixed, then fine, great. Yeah. But absolutely. At least you've fulfilled your role, if you like, and given them the different options.
Fantastic. Nigel, thank you so much, mate. It's pushing 9:30 on an evening, and I know that you've got work in the morning, so I really appreciate you spending this time with me today.
It's a pleasure. But first of all, thanks for asking us down for the summit. I thought it was great. We had a really, really good day. It was tremendous. The people you got together, Pav, we had a great audience. It was a pleasure to be involved. And like we said, hopefully we'll build on that next year.
Yeah, really appreciate it. So, Nigel, if people wanted to find you on social media, what's your Instagram handle? How can they how can they find you?
First of all, my website, which is just nigelhargreaves.co.uk. Instagram is just Dr. Nigel Hargreaves. We are running an overdenture, a one-day overdenture course in May next year, 17th of May.
There we go.
And if you sort of want to get involved with that, then you can contact through the website. You can contact Joanne, who's my course coordinator, Joanne at nigelhargreaves.co.uk. Before that, we have a 2-day restoring implants course, which is just general restoring. That's fixed and removable. And that's a 2-day course held in Leeds on the 28th of February and the 1st of March. So again, if you're interested in any of these, then please drop us a line.
Yeah, so what you're doing now is you're just doing like gentle introduction to restoring implants, effectively.
Yeah.
Like you just
across the board. Because again, by doing a 2-day restorative course, we can go from single tooth restoration. Because the guys that tend to come on these courses, we've got all manner of experience.
Yeah.
So we've got some quite experienced guys, we've got some beginners. So we'll go through restoring single implants. I think one of the things now is because obviously more practices have implantologists either within the practice or visiting implantologists, that a lot of the restorative dentists could be restoring these cases. So we're showing guys that are more from a restorative or cosmetic background how to restore single teeth or small bridge units, but we also extend that to overdentures and through to full arch fixed restorations. So that the practice that I sort of trained in, we had implant surgeons and we had restorative dentists. And so it's nice for guys within the practice situation to be able to restore. And I do think if you spend a few years restoring, that sets you up perfectly to move then into the surgical aspect, because you've come across quite a few of the problems that maybe somebody that is only doing surgery doesn't appreciate and see from a restorative aspect. So I think if you're restoring implants for a while first, that gives you a perfect introduction into surgery.
Yeah, absolutely, mate. Nigel, thank you so much, mate. So I think what we need to do is we need to get our heads together over a curry and a beer, and possibly look at doing like a 2-day course between ourselves as well, mate. I think that would be a lot of fun.
I'd love to. I think we should, Pav. I think we should get together and plan something.
Yeah. And for those of you who are my delegates on the Academy of Implant Excellence, listening to this, don't worry, Nigel's going to do a session for us on overdentures.
Yep,
because he's a busy man. Okay. Right, so what I wanted to mention as well, mate, is you might have seen is I was in Cuba last week with a group of delegates.
Yes,
and the team placed 260 implants in 4 days. There was 10.
Wow.
So all the delegates got to place 30 implants each. It was a fantastic way to
it's amazing.
Careers. It was a lot of
fantastic.
Fun, a lot of hard work, a lot of fun.
Yeah.
So for those of you listening, you know that I have the Academy of Implant Excellence. There's a lot of ways that we can help you with your training. I am going to be doing things with Nigel as well, but we do offer hands-on courses as well. It's quite intensive, being immersed in it for a week. We have an oral surgery course where you just go and raise flaps, remove bone, take out fractured teeth. There is an impacted eights course as well, where you just take out 20 impacted eights. And then obviously we have the hands-on implant course as well. So it's a great way to get a lot of experience in a short period of time. And what these courses are designed to do, they are not designed to make you into an expert overnight. They're designed to give you the confidence to start implementing, and then the rest of your journey continues from there. That's what
I think that's quite interesting, Pal, with you saying that. I think that on the mentoring circuit, I come across quite a few guys that have maybe been more of a general practice background or a restorative background, and they've then entered into an implant course and they've learnt the surgery from that aspect of things. And generally, you tend to find that the restorative dentists are a little bit tentative with flaps and incisions and bone removal and grafting.
That was me, Nige.
Sorry?
I was heavily restorative based. I did a Chris Hall's course, Mike Wise's course, went to America to do Frank Spear's course. I hated blood, because if I saw blood, that means perio was there. Yeah. And I was petrified of raising flaps. So that person that you're describing is me.
And similar to me, because I spent 4 or 5 years restoring before I started doing any surgery. But the course that you just mentioned last week, what I find on the mentoring circuit is the guys that have been away and done these sorts of courses, these intense week courses where they're placing 20 and 30 implants. When you see these guys in practice, they are so much more confident and more adept to doing these cases than people who haven't, who've only done courses and have been one-to-one mentored. To go away and do this sort of saturation course really, really does improve their skills no end.
Yeah, absolutely agree, mate. Nigel, really appreciate your time this evening.
Oh, thank you. Thanks for the invitation, Pav.
We'll definitely have to meet up again soon.
We will.
I'll leave you to the rest of your evening, mate. Thank you.